Okay, so let me say thank you to everybody for tuning in today for a wonderful discussion with our Dr. Brett Tombs from Montreal, Canada. And I want to say thank you, Doctor. I've dealt with you in the past, so from that ways, it's a pleasure to work with you again. And now I'd like to turn it over to Michael, who will now give the proper introduction for the doctor and for today's presentation.
Hi there, I'm Michael Bessert. I'm the patient advocate, and I want to welcome everyone to the Scleroderma Foundation Michigan Chapter's web-based educational series. This webinar is being offered as part of our strategic planning efforts to move towards web-based learning experiences for the next 4 years in an effort to reach more patients, caregivers, and family members who are seeking to obtain accurate information about scleroderma. These webinars reach scleroderma patients and their family members from all over the world, emphasizing the importance of quality educational programming for the scleroderma community. This educational program is made possible in part by grants from Actilon Pharmaceuticals US Incorporated and Boehringer Ingelheim and the Trico Foundation, and we thank them all for their continued support. Today we have presenting as Dr. Brett Tombs, and he completed his PhD in clinical psychology at Fordham University in 2004, during which he did his clinical internship training at Weill Cornell Medical College in New York. He was a postdoctoral fellow and instructor at Johns Hopkins University School of Medicine before coming to McGill in 2006. Dr. Tombs is currently a senior investigator at the Lady Davis Institute for Medical Research, Jewish General Hospital, and professor in the Facility of Medicine, McGill University, the Department of Psychiatry, and associate membership in the Departments of Medicine, Epidemiology, Biostatistics, and Occupational Health, Psychology, Educational and Counseling Psychology, and a Biomethical Ethics Unit, Dr. Tombs is internationally known for 1, developing, testing, and disseminating educational self-management, rehabilitation, and psychological interventions for people living with the rare autoimmune disease of scleroderma. 2, his work on depression screening and the evaluation of depression screening tools. And 3, meta-research, which involves examining how the design, conduct, and the reporting of medical research may lead to bias. Since he came to the Jewish General and McGill University in 2006, Dr. Tombs has authored more than 300 articles, including more than 270 peer-reviewed articles. He is the principal investigator or co-investigator on numerous grants for the CIHR, the FRQS, and the NIH in the United States, and several other private organizations, including the Arthritis Society, Scleroderma Canada, and Provincial Scleroderma Patients. And I, as a 7-year SPIN participant, would like to welcome you to this presentation today, sir. Thank you.
Well, great. Well, thanks, Mike, and thanks, John. Thanks for the introduction, and thanks for participating in SPIN, Mike. And congrats right off the bat for all that you do in Michigan. It's great to be there. Well, not really there, I guess, but great to be there from here. But what you're doing at these seminars is tremendous. And I know Laura Diaz works with us in our a number of our programs. So I know through her that a lot of the other programming you offer. So really kudos to all of you, and thanks for doing this. So I'll talk today about how to make healthcare decisions. And that's something that you'll face obviously a lot when you live with a disease like scleroderma. We all have to make decisions, but they come faster and more frequently when you live with a disease like that. Okay. Just to disclose, so this presentation did not receive funding from anybody. So just to let people know that up front. So how do we make decisions? There's a cartoon here, but traditionally the doctor might say, when we want your opinion, we'll give it to you. Yeah. Or take it or leave it. Here are your options. And traditionally, in medicine or in any kind of healthcare, you were trained to let people know what the best choice was for them. And that was called, evidence-based medicine. The experts know, and they'll let you know what the best way forward is. what's happened over the last decade or two are a couple really, really key innovations. One is evidence-based medicine, which means that, you know, when we only see a certain number of things in our own setting, we don't see enough of any given scenario to really know what might happen next. You know, again, in healthcare, we're trying to predict the future. What would happen if we don't do anything? What would happen if we take option X or take option Y? And you know, most physicians haven't seen so many of your particular problem that they can be quite sure of that. So we use research evidence to help us try to figure out what would happen next. The other thing that we've learned is how important patient values and preferences are. Is that sometimes you can predict what might happen next, but those things don't mean the same thing to everybody. Just to give a really simple example, someone might prefer that to go to, you know, to do whatever treatments would extend their life for whatever reason possible, no matter how difficult that life is going to be going forward, because it's so critical to them that they're around as long as possible. Someone else might take another option that might not extend life as much, but has a lot better quality of life, you know, whether it be a cancer treatment or whatever. It would offer that often is something that people are faced with in cancer, for instance, in later stages. And then no one can tell you what the best decision is. It depends what's more important to you. And I think that's a key factor that cuts across all decisions, that or most decisions, that there are all different options, and it's important that what's important to you as a patient has a prominent place on the table. So evidence-based medicine should integrate, you know, all three of those ideas. You know, what's the best evidence from research, what your clinician knows about you and your particular problem and his setting, and what you think and what's important for you about the different outcomes that you might achieve by making different decisions. Now, what does evidence tell us? You know, we're not dishwashers for whatever it's worth, but you know, if the dishwasher repairman comes in your home and looks at the dishwasher and is doing a good job, they can usually see that, you know, whatever part is missing or has come loose or is broken, if you replace that part, the dishwasher is going to work. They all work the same way. We're not built that way. We all have lots of things that are different about us. No two people are the same. And that's more true in scleroderma than anywhere else. So, but evidence can tell us what would be likely to happen. It can't tell you for sure, but it can tell you how probable something would be if you take a certain option. So that's what evidence means. So for instance, now these numbers here on this are not necessarily the right numbers, but just to illustrate, but if you have depression, which is an area where I work, and you take an antidepressant, again, not everybody benefits from the antidepressant, but we know that about 6 people out of 10, these are actually approximately right, maybe 6 or 7 people out of 10 will get better in the first 3 months of taking antidepressant, whereas 5 people who don't take one would also get better. So again, you don't know what's going to happen to you. You don't know if you're really the one that gets better or not, but you know about how likely it would be to happen. If you get a hip replacement, I had one of those a few years ago. 8 out of 10 people have significantly improved mobility. Again, you don't know if you're one of the 8 or you're one of the 2 that doesn't have that happen, but you know about how likely it would be to happen, and so forth. But on the other side of the hip replacement coin, you know, about 1 in 300 are going to have a problem. Now, it's not a lot, but having to do it again very soon after you got the first one done is a big deal. So there's usually 2 sides of the coin. Anytime you go and make a decision, there's good things that can happen, and there's usually some bad things. They can be serious bad things, or they can be just a nuisance. But you want to know how likely those things might be to happen and what they are. This is a classic evidence of it, or a classic case of this. And this comes from my work on something called the Canadian Task Force on Preventive Healthcare. And again, these are approximate numbers, but we often do screening to try to find diseases ahead of time. And these are, you know, we do these when you don't have a disease. We want to see if you might have it inside and it could be growing. But breast cancer screening is a good example where if you decide to get screening, out of every 155 or so, 150 or 200 women to get screened, one of them is going to live longer because of this. And that's important. So your life could be extended. On the other hand, about 1 in 4 we have a false positive screen, meaning that someone says, well, you know, it looks like you might have cancer there, and you'll have to get more tests to clear it up. One in about 28 will have a biopsy, meaning they've actually got to go through and do some, might be painful short term, but they'll do some more investigation. But then about 1 in 200 might have a part of a breast removed for something that never would have bothered them. So there's good side things and bad things, right? And so what's the right decision? Should someone get screened? It depends what they value most, right? Do they want to value the survival benefit at all costs, or do they want to avoid some of the things that happen that would avoid by not doing it? And again, that's a patient value and preference question.
Doctor, I have a question for you.
Yeah.
Is that one of the things that we have with what I would say my generation and maybe the older generation, my generation older, is that we all have this, how can I say, preconceived notion where, you know, the doctors are gods. In other words, when I say that is that it's that idea is that when they tell you something, the patient, either because of the information that they've been told, which is normally a bad scenario, they don't push for the additional information. And how can we help that patient be able to ask the better questions so he can make he or she can make that informed decision?
You know, if it's okay, John, and I have a whole second part of the presentation. I'm going to walk through a bit of a template for how to have a conversation with your healthcare providers that might get
beautiful. That sounds great. Thank you.
Perfect. Thanks. No, thanks for bringing that up. That's the key question, right? And I have to say, you know, our physicians are tremendously well prepared. The amount of training they go through and is incredible. But the question comes again, you know, how are we going to consult with them? And this is what we're going to talk about, another idea called shared decision making. So if you're going to make the best decision for you, you don't want the way that we use this resource, which is our doctor, is not for her or him to tell us what they think they would do. They might have different values, but to give us the information, and they should know that information, and most of them do know it quite well. We have great docs in our scleroderma community. So if you ask them for this information, you know, if I pick, what happens if I get a stem cell transplant? What are the outcomes? What happens? What happens if I don't? There's research on that. And they should be able to provide you that information. And they're a tremendous resource for that. So they can give you that kind of information and then help you do that. But again, we want to make sure that you're involved and have ways to do that. We'll talk about how you can do that. And again, this shared decision making is going to take into account your own values, the best evidence out there, and your own particular characteristics, which your doctor will know, right? Why might your scleroderma be different from somebody else's? And what we want to do is we want that, you know, you to feel comfortable and confident working together with your doctor to get the information you need and make the best decision for you. So, you know, so that you actively participate and you really share the center of this. And what is the role of the doctor? It's going to let you know what your choices are, first of all, right? Sometimes you don't have many choices, frankly. Other times you might have 2 or 3 or 4 options. So what are those options what's the list of options you have? What might happen with each of those options? And then you know, someone who's good at this can help you do. They can help you understand how things that are important to you might be better or worse served by each of those options, if that makes sense. So they've kind of seen this at a big picture level. What do we know about this? There is some decent evidence that when the patients are engaged more in making their decisions, they do have a better sense of control. You know, they usually get outcomes that more fit what they want, and they feel better about it. So I think it's important to do this. Now, this comes back though to what John, you were saying. The reality is though, is that when people rate encounters between doctors and their patients, shared decision-making doesn't happen a lot in practice. So we can't assume, and this is somewhat generational, which you mentioned, John, what the generations. I think younger doctors coming out are being trained in this more often. People who came out of medical school decades ago, maybe less thinking along these lines. But so you're going to be more likely to have this happen if you're prepared to go in and have a conversation with your doctor and ask some of the kind of questions that are important to ask.
One of the things that I've always stressed when I was a caregiver is that any type of exams or follow doctor's appointments is that I always try to make sure I was with my wife as part of um, that office visit, because if there is bad news, as most people do, we shut down and we focus on exactly what's happening to us at the moment. And we don't hear all the things that the doctor is telling us. So I always try to, express to new patients or caregivers to make sure that you go with the patient, you go with your loved one to hear what the doctor's saying. So basically, like you said, when you're saying shared decisions, that people have four ears that are hearing the message, and not just one that basically might have been compromised because of the news that they just received.
That's a fantastic point. I think, like you said, there's two reasons for that. One, when we get this rough news, it is very hard to take in any kind of information at that point. And having a second set of ears and eyes is good. The other one too is that this stuff is sometimes very complicated, and we all just miss, even aside from the emotional part that you mentioned, it's tricky. And so if you have a second person here hearing all of it, when you discuss it, and you should discuss it, one of the things I'll recommend is before making an important decision, you discuss it with a loved one who knows you and so forth. But if you have a second set of eyes and ears there, maybe if there's a little bit of a misunderstanding, or that you point out, and are we sure we understood this the same way? And maybe go back and get information you're less clear about too. Can be really helpful. So what about decision making? Some of these decisions are no-brainers. If you have a traumatic accident, if you break your leg, you got to fix it. There's not a lot of decision making. Sometimes you got to go to it. Other decisions though might be a lot harder. I mentioned cancer before, or late stage cancer, if you want to continue with very rough treatment or not, and live your life, better quality of life going forward, but understand that you're not going to be able to go forward longer. That's a tough one. Or maybe on a less dramatic scale, what about taking a new medication that might help you with a symptom, but also comes with some side effects? And outside of scleroderma, I mentioned antidepressants are a good example. They help some people with their depression, but they have some nausea and some sexual side effects and other things that go on. And so it's again, how do you balance that, and how do you make that decision? So what are some easy steps when you think about going in your doctor and when you're going to make a decision? Now, and sometimes when you're going to have to make a decision before you go in. Other times you have less time to make that decision. But I think those times are usually rare. I mean, usually it's only in urgent situations when you have to make a decision on the spot. And that's something that's important too, is know that you usually don't, most cases you don't have to decide right then and there. You can go home and think about it, talk to loved ones, and come back and make your decision. And that's really key to keep in mind. But the first step is just make sure you understand what all the options are. And, if someone says, here's the problem you're having, we often recommend this, just clarify, is that the only option, or are there other options? Can you tell me what those are, even if you don't think they're very good ones, just so I understand? And make sure, you understand what your each possible pathway that you might have to choose from. Now, not always, but point 2 here, not getting treatment is an option, right? So you want to explore that just like an option. What are the good things and the bad things that'll happen if I don't do anything right now? Either I never want to treat this, or what if I delay it? What if I wait for a month? What might happen then? That's a treatment option, right? One option might be treat it now. Another option would be, I want to wait and see and come back and decide in a month. So that's a treatment option, and you want to understand the pros and the cons of that too. How much would your course change over that month? Are you putting yourself at risk if you do that? And then finally, in most cases like this, there are no black and white or right or wrong answers. Again, if you remember I showed you this the die, you're rolling the die here. They're about probability. There are no guarantees, good things or bad things that might happen. You want to make your best bet, and you want to make one that's most consistent with what's important to you. And that's really the right answer. The right answer is the one that comes when you've gotten information you understand, You thought about your values and what's important to you, and you make the best decision that's most consistent with that. That's the right answer. So how do you understand what are the pros and cons of these things? And there's a lot of information on the slide, and I think John, these will be available to people. The slides, correct?
Yes.
Okay. So think about what's important. Figure out what the pros and cons are, and figure out which ones are most important to you. If you could look at the example, is it most important that you stop progression of the disease as fast as possible and make sure that happens as well as you can, or that you avoid side effects? You know, let's imagine there's a respiratory side effect that might make it harder for you to walk, and that's important to you. Do you want to, you know, which one's more important? So make sure you understand the pros and cons, the benefits and risk of any decision, and ask your health care provider to express these as much as they can in what I call concrete probabilities. If they say, you know, many people experience, you know, it's going to slow down their progression of the skin hardening, how many? We don't want to hear that the odds are 2.2 or things like this. You want to hear, well, usually, you know, 9 out of 10 people experience a benefit, or, you know, about 55 out of 100 experience a benefit. Ask them to put it in numbers like that we can all kind of get our hands around more easily. Include the cost or convenience of each option you want to think about, right? I mean, that's part of the benefits and the cost. So if there's a treatment that's being suggested, but requires you to go into a facility once a week for an hour, but your drive is 4 hours each way, or, you know, that's part of the math, right? What's it going to cost you to do it? And how do you weigh that out? So make sure you understand all those. So make sure you understand the cost and how easy it is to do. And then again, as I keep emphasizing, what's it mean to you? Okay, that's the most important thing. Now, clarify which option your healthcare provider recommends. So I've been talking about doing what's most important to you, but it doesn't mean I wouldn't ask the healthcare provider what they might do. That seems to me a reasonable question. But the purpose of that question is not just so you do what they think they would do, but it helps you maybe to think through some of this. It helps, at least for me, it helps me to look at someone I trust and respect, how they think through a problem. So, well, if this were you, what would you do? And why would you do that? And then that might help you you might come to a different conclusion, or you might come to the same one, but it might help to see how someone thinks it through those options, if that makes sense.
No, when I normally, what we used to do is, that's a great point about asking the doctor. And it was more like, you know, if this was your wife, or this is your daughter, or this is your son, what were the recommendations if the same conditions was presented to you, and why would you choose that option? And that's a great input, because a good doctor will give you what his, you know, what they think, and they'll back it up with the rhymes and the reasons why they think it's important.
Yeah, no, thanks, John. It's a good example. Yep.
And another example is me being the patient advocate. When my diagnosing rheumatologist was an old-fashioned doctor, and he told me, after he had excused my wife from the room, that I had scleroderma. I needed to put my affairs in order, that here's a brochure. If I have any more questions, Google it. He was going to recommend me to the University of Michigan Scleroderma Clinic, and that he's leaving for lunch if he's got any more questions, to see his receptionist. Okay, second diagnosis, honest to God, August 1st, 2013. Forward 2 months to October 5th of 2013, my first appointment with Dinesh Khanna, and he blew everything out of the water that doctor said. And he validated what I was going through, and he restored my hope. And that was 7 years ago. So it is good to get other opinions, and doctors aren't always right. So I'm tying that in there because it kind of, you know, blankets both of what you're talking about. So doctors are not always right. And so it was a tough way to get a diagnosis, but it's also why I'm an advocate today. So I just wanted to throw that out there.
You know, that's an important point you're bringing up. I'm sorry about that experience. Gosh, it's terrible.
Yeah.
What an awful experience. But it also talks about too that, you know, like any other thing, someone you trust should be able to tell you when they don't know. And
Right.
and that's a key point, because no general practitioner, I mean, they made the right referral and you got to a great outfit,
Yes.
but they didn't have enough information to be making that prediction by any means, of obviously not. So that's an important thing. I mean, the best doctors out there should be telling you scleroderma is a complicated disease in any case. So
Mhm.
I don't know if you go with Dinesh or Fred Wigley at Hopkins or John Varga, who's now at Michigan also, or all these other great clinicians out there around, the Maureen Mays. I could name a name.
Oh yeah.
I've just left a bunch of people out now. That's the risk about naming people, because there's a ton of good ones. They're going to tell you they don't know at some point.
Right.
They'll tell you that I don't know and I'm going to get more information for you. Or they'll tell you I don't know and neither does anybody else, because that's what the research says. So that's an important point, though. Make sure your doctor knows. Should be able to at some point say they don't know.
Right. And the original rheumatologist told me that I had limited. And so I was re-diagnosed by Dr. Khanna as having diffuse. But he also, like I said, he said, well, the doctor, said you're going to die, but he goes, we all will. We know that's a fact, but he goes, we're going to prevent everything he gives. But but he also explained to me my two choices, as we were talking about earlier, to do chemotherapy, which my wife had been through 17 years prior. And I knew what the negatives on that were. Or I chose the CellCept because he gave me the information on the CellCept. But it also wasn't an immediate decision. So I went home, thought about it, and I chose the CellCept, and best decision I ever made, because I'm stable and doing great. So
That's fantastic. That's great.
yes.
And one of the points you just made, I have here on this slide actually, is that make sure you're ready to make a decision and have the support. One of the things you mentioned, take some time to think about it. Go through the options. Good doctors will respect whatever you decide, including that you want time to think some more about it, right?
Yes. Yes.
So, another point here, make sure that you have the resources to carry out some decisions that are recommended. So that's important too. That could be, depending on the healthcare. Well, in the States, you're going to have to think about how much it's going to cost you and you can afford it and things like that. But the resources could be, do you have childcare if you need to, if to go to the office every week or whatever might be involved. And if you don't have those resources, some of those resources you could talk to people at the chapter and so forth and see, and they can maybe help you problem solve and how to get them too. That a lot of these problems are surmountable, but make sure you have the resources to carry out each of the options that's being described to you. So one of the best ways to make sure you get what you need, and I don't have slides as I should have, is to prepare for your appointments. Prepare before you go in. What are some questions you have, and actually make some notes before you go into your appointments. What are the things you need to know, and sometimes you have to think about those things on the spot. If the doctor tells you about options, you won't know what questions you have right off the bat. But you can always, like I said, come back and ask them later. This is a tool that we've made at Spin that really lets you think through the options clearly. We didn't actually make this; we adapted it from another group in Ottawa. But it really helps to look through, lay out what your options are. And I'll go through and give an example using this table. But you want to know, for each of the options you'll see here, and I believe, John, I sent you a copy of this. If people would like to have a copy of this, they can use. But for option number one, what are some good things that could happen if you do this, right? What are good things that can happen from making this choice? What are some reasons to maybe avoid that option? What are some bad things that might happen if you choose option one? And just list them out. And you can go through that with your doctor or do it, whatever you're comfortable. Go through it, draw them down. And you want to know, if you're really sophisticated, and the next column over there says, how likely is this to happen? If you're more comfortable with numbers, you might put that numbers. Well, 65 out of 100 people experience, and keep it that level. Otherwise, you can simplify it. From very unlikely, it's really rare that this happens. A lot of times some of the drug side effects are important, but they're really rare, whereas other ones are much more common. And so what's a bad thing that can happen, but how likely is it to really happen there? And then the last column is really key. How much does that particular side effect matter to you? Whatever it's worth, antidepressants have sexual side effects. That could be critical to some people to avoid those, depending where you are in your life. Otherwise, other people it might not matter at some point. So that's another one. It may have, there's completely different assessments of different outcomes, right? Okay. So I have a case here on these slides. I don't want to go through this, and read in detail. It's a fairly typical case here, but people can look at it otherwise. But if you can imagine, there's a woman. This is a typical scleroderma presentation of a woman who's about 40 to 50, has children, she's active, and she begins first with color changes in fingers and blueness. So she's got some of the Raynaud symptoms coming on, and then a few months later, she starts to get some of the more clear scleroderma symptoms, right? She's puffy fingers and stiffness and so forth. And so her doctor refers her to a rheumatologist. And who again noticed some of the same things I've been talking about, thought that there were some finger contractions beginning, tendon friction rubs and so forth. And did some tests. And again, I won't read through all this stuff and all the tests they went through. You're all welcome to go through that. And the results were dual. There was some good news that aside from the Raynaud's in the skin, she didn't seem to have any organ involvement, but she did have this anti-RNA polymerase FLT3, which can be associated with likelihood of your skin thickening progressing more quickly than some other people who don't have that. And so the doctor explained that if that were to happen, now it's not certain, right? Because when you have these indicators like this, it just means you're more likely to have this happen, but it doesn't mean it's certain that it's going to progress. But the doctor explained that if it were to progress, that would become permanent. So you're not able to walk that one back. It was the concern. That's what the doctor explained to Belinda. That for now, the skin involvement was fairly mild, forearms and lower legs. But he couldn't tell her for sure if it was going to progress or not. And again, this is a fairly typical scenario that you're faced with in this disease. So some indicators that it's likely to get worse, but not certainty, right?
Mm-hmm.
So, what were the options? Basically, the rheumatologist explained that methotrexate's an option, that it can limit progression of skin thickening. It's commonly used. There's a lot of evidence in rheumatoid arthritis. We use it all the time in scleroderma. The evidence and studies in scleroderma aren't as good, and the effect maybe isn't as strong as in rheumatoid arthritis. But there is a sense that it does have some benefit to it, that it can stem the tide. But there also has some side effects. So whether it be possible fatigue, hair loss, diarrhea, ulcers in the mouth, to some worse ones that are more rare, like hepatitis and bone marrow suppression. It involves blood tests every 6 to 8 weeks to monitor for side effects. And it costs about $20 a month. And this is outdated, so maybe it doesn't cost $20 a month anymore. And it probably depends on copays and that kind of thing. But for the example, we use that number. Now that said, if there are problems, some of the side effects, the methotrexate could be stopped, and the side effects are reversible. And that's an important thing to think about. If you take a route and it doesn't go well, that's an important question. If you stop it, will it stop the process, or is it too late? Are you all in, right? And that's what they think about. In this case, if you take the treatment, it goes badly, you stop it, and you stop the side effects. Yeah. So she asked if there were other options, and the options that rheumatologists provided were a few. She could wait to see if it progresses before deciding to start a medication. The main downside was that if it progressed, the methotrexate could be introduced later and maybe stabilize at that point, but it wouldn't likely bring her back to where she is now. And there didn't really seem to be many other options. So essentially the option she's facing with her, start methotrexate to try to prevent her skin from progressing, or just wait and see how it went and make a decision later. Those seem to be the two options she had. So option one is start the medication, right? And what basically it's it could help soften the skin and slow progression. After discussion with her doctor, she thought it's neither likely or unlikely. So it's not certain. It might do it, it might not, but it's not, no guarantees on her part if that would actually, she'd get that benefit or not. And then the reason to avoid this were fatigue, possible hair loss, diarrhea, and then much less likely were things like hepatitis and so forth. The cost per month is a 5, right? It's not only very likely, it's certain. She knows what that's going to cost her. Okay. And the blood test as well. So how important are these things to her? And that's going to be an individual decision, right? On how important each of these is to her. What about step 2, waiting to see if the skin involvement progresses? Well, if she waits right now, she would avoid the side effects, the cost, and inconvenience of the treatment. That's for sure, right? At least now we know she would avoid them because she's not taking the drug. But it could progress more rapidly and not be reversible. And that's the doctor thought that was pretty likely to happen. Okay. So what do you do with this information? It's important to make sure you have information, right? Make sure you create a list of questions. And again, I didn't, by the way, fill out how important this is, because I think it's hard to say that every one of you would go through and fill out that, how important these are to you on your own. But make sure you have enough information. Create a list of questions you have about each situation, each option. Clarify with your healthcare provider. And you might have to look at medical pamphlets. I wouldn't go to the internet. If you see something on the internet that makes you skeptical, ask your doctor. There's often something we don't understand. Don't be afraid to ask for a second opinion. I mean, good, comfortable doctors won't be offended by that. I mean, so ask them if someone else might have a different read on this or a different opinion, and maybe go get one. Make sure you weigh each potential option, right? Discuss it with your healthcare provider. Talk to other people who've experienced this. And this is critical. I mean, this is for an example. If you could talk to people with scleroderma who've gotten a stem cell transplant, the story, some of the stories they tell and what was involved in it don't really get captured in the research evidence, right? Did you have to move to a city closer to where you get the treatment and stay in an apartment and have what kind of support you needed? These are important to understand. If it's possible to talk to somebody, if it's a big decision and you can talk to somebody who's been through it, that's sometimes a very good resource. Now, keep in mind, you're very different than that person in terms of your physiology and biology, so you can't expect the same outcome, but you can expect what it's like to go through it. That's probably, you can extract that from their experience. Fill in your table. Look at get it really concrete. Because this is, John mentioned the idea of you get tough news and the stress involved earlier. Get it down on paper. Help yourself organize it. And then the third box here, make sure you have enough support. Like I said, go through the table with your loved ones. Talk through it. They might think of something that, that seems off to them. You may have forgotten. And make sure you're not feeling pressure to make a certain decision. Take some time. And again, make sure you have chosen the right option for you. You can go through the steps again. And again, make a good option is waiting sometimes. If the doctor says if you don't act now, all sorts of bad things are going to happen, you might have to make your decision sooner. But usually you can take some time to make your decision, just to think it through carefully. Go through this, have a conversation with your loved ones, put it aside and come back to it in a few days when you've had a chance to let things settle a little bit and look at it again. So that's just a little bit of a template that we've drawn up at Spin, to try to help thinking about making the decisions you have to make. And I just want to wrap up by, thanking all sorts of people who supported us in all this work. So a lot of, we get a lot of our funding from the Canadian Institutes of Health Research, which is our version of the NIH, down there. And lots of scleroderma patient organizations that support us. And we're really, really grateful for the groups that do that. It helps us do this kind of work and all the other kind of work we're doing. So thanks to everybody. And I guess John and Mike, should we have any other questions we should go through?
No, I just want to say thank you, doctor, because one of the things you do is, like I said, my background when I was working was project management and analytics and you know, doing the quality things. And what you really do is that, you know, you help the patient here try to make a more logical and real rational decision, trying to look at facts and fit and numbers versus an emotional decision. Now, granted, it's always going to be an emotional decision, but you know what? It's good to be able to take a look at what are your outcomes, what are the trade-offs, what are the things that are important. And what you presented here really is a great tool to help the patients and the families, because you know, people will question, you know, the patient as being, why'd you do that? And you can say, well, here are the other things and you know that can happen, and here are the trade-offs, or this is what I'm hoping for, and that's the most important thing to me. So I want to say thank you, because this tool is very important to, you know, help the people feel a little bit more confident in their decision, and also is that how you're going to say explaining it to others on why they make a decision. So thank you.
Oh, thanks. Those are great points, John. Thanks for the comments you made throughout the presentation.
And I'd like to add too, is I skipped a part in your introduction that SPIN stands for Scleroderma Patient Intervention Network. And a point I'd like to add also, doctor, is being the sclero advocate, I'm also a patient peer mentor. And after a brief description of how I was diagnosed, for the peer mentoring I do, I call it the deer in the headlights. So, you know, I kind of got, you know, the deer in the headlights with my diagnosis at first. So I help other people go through that. And I also emphasize what you did too, is it's that everybody is different. And I'm on all the support groups on Facebook and all that stuff, and they're not supposed to give medical advice. And I am forever, ever telling people that everybody has different comorbidities. There's not nobody is the same with this disease. We all present differently. Everybody reacts differently to medications. So the giving of advice and stuff, and especially like for the newbies, is like you said, make your list, follow through, ask the questions. I fired a couple of doctors in my time, but it's because they either weren't listening or they just were on their own agenda. And so, you know, that's how it works. But no, this is very valuable information. I want to thank you very much for presenting today. That was great.
Oh, no, thanks. Those are great points. And thanks for clarifying that SPIN means what it means, because you might think that SPIN means that you're not telling the whole truth. That's a big problem these days. So I think.
Right. Right. Well, it was in there, and I think I skipped over that one paragraph, but it's a very long intro. So my apologies, because I was reading back. I skipped a paragraph where it explained what SPIN was. So I apologize, but I wanted to clarify that.
No, thanks. And you know, I think it's a great point about the medical advice. Because remember, you know, I point out these are probabilities and numbers, but you know, it might be that those numbers only apply to people that are doing research on it. And if you have a certain profile in your scleroderma, it might be a no-fly zone. Don't take this drug because these kind of things might happen, or don't do this at home because if you have this, that could happen. If you're not talking to your doctor about your own condition and doing what someone else is doing, no one with scleroderma is the same. And so you need to get some context on how these numbers apply to you and what they are. And without that context, you can really do some damage. If I can make a quick plug, by the way, we're starting a new program in January in SPIN, the SPIN Self program. So it stands for self-management. Self-management's a bad term, but we use it in the industry per se, but it doesn't really mean managing by yourself. It means learning skills to manage your disease more confidently and to work with your healthcare providers more effectively. So we have these programs are used all the time in arthritis and cardiovascular disease and common diseases that are well developed. So we've worked with a group of patients and put together a scleroderma specific program, and we're going to begin running in late January. There will be groups, so we'll meet like this online for an hour or so, once a week for about 12 weeks to go through the program. So we'll be recruiting people to join that program in late January. So we'd love it if people keep your eyes out and join us on that if you're interested.
I'll probably be one of them because I did the SPIN program through the summer dealing with COVID, and it was wonderful. I'm glad I had the opportunity to be part of that. It was very good. I'm very glad I participated. Yes. Yes.
Well, good. Well, thanks, Mike. I'm glad you like that, because I have to say, like, we put that together in a flash, many people in our community almost killed themselves doing that. So I'm glad you found. I'm glad
Oh,
helpful.
it was wonderful connecting not only with scleroderma patients from. I was one of 3 in the United States. There was a Filipino living in Germany, and there was an Australian living in England, and then 3 or 4 Canadians. And so it was great to get not only everybody's perspective about scleroderma, but about COVID. And we kind of formed a great little family. So it was very fun. So thank you. That was great.
Oh, great. Well, thanks for mentioning that. You should have seen the person on my team who had to schedule those things. We had people from 10 countries, from Australia.
I could only imagine. What a nightmare.
All the way across to the Western US and Canada. It was an incredible task just to put the groups together.
Well, they did a fantastic job. So kudos for them. So
thanks, Mike.
Yep.
So Michael, why don't you wrap this up and give the, like I said, I'll just say thank you again, Doctor.
Okay. Once again, thank you, Dr. Thombs, for presenting today for the Scleroderma Foundation. I know this information has been beneficial for all of us. I want to thank all of you for viewing the webinar. Staying educated about scleroderma is so important. This is the reason the Michigan chapter strategically has created web-based educational experiences. Being educated can help the scleroderma community become better healthcare advocates. I hope you'll join us for all our educational webinars. And for more information, check out our website, all small letters, scleroderma.org/Michigan, or the National Scleroderma Foundation weekly e-letter that is delivered to your mail every Friday. Thank you again, everybody, and have a wonderful day.
Thank you.
Great. Thanks, guys.
Thank you, sir.
Oh, thanks a lot. So we're all set, right?
Right. Bye-bye.
Yes.
All right. Take care. Have a good one.
Thank you.
Bye.